Evening, friends. We warmly welcome all of you for this evening postgraduate clinics. We have a very important talk, which is the continuation of the last 3 weeks. The first talk was on instruments and regarding the instrument Viva by Professor Khanna sir, and then last week was the basic X-ray talks part 1 by Dr. Rajgopal Shenoy sir. Now we are moving on to the advanced imaging part 2. This will be covering upon CT scan, mammogram, ERCP, and ultrasound. So, friends, we look forward to hearing to Professor Rajgopal Sinha sir for his talk. Good evening, sir. Please share your PowerPoint and start your talk.
Yeah. Is it visible?
Yes, sir. Yes, sir. We are able to see you well, sir.
Yeah, if you tell.
Audio is also good, sir. Please proceed, sir.
Yeah. So, thank you very much, Dr. Kanakwel, for this second session. Let me tell at the beginning that sonology is imaging is something which is grown very, very large, proportions. The idea is that we are trying to help the students, maybe in their examination, or maybe in their OSCE sessions, or maybe in the Viva session, or maybe in the long case, all the cases, short case, long case, the imaging nowadays will be asked. So keeping that in mind, I have prepared. Nevertheless, learning has no end. So I hope you will study further deeper. So with this, we'll start with the basic ultrasound. This is the one modality, which came in a big way. Is basically a piezoelectric effect, which is the property of certain substance which convert the electrical energy into sound energy. So these are the active portion of the ultrasonic transducers, and a commonly used substance is a zirconate titanate. So that's the PST. So applications, as you know, it's basically a high frequency. Gives a excellent resolution images, only superficial structures. Now, if you look at the examples of the high frequency, classical example is a joints, thyroid, scrotum, musculoskeletal system. But if you go into the deep into the abdomen, it's basically a low frequency probe. But remember, low frequency has got a greater penetrance. So you would have heard probably in last a few years, some of the commonly asked question of everyone that what is the, the frequency of this ultrasound beam. So you can remember from 2.5 to 15. This is how it is. So as I mentioned already, deeper in the abdomen and obstetric and gynecological, it is less, 2.5 to 3.5. And if you go into the superficial structures like, subcutaneous lipomas, sarcomas, it's 15. Some are in between. I put the range from 5 to 10. Depends upon the, transducers which are available. The classically breast, thyroid, all these superficial veins, parotid swelling, they all come under this. So 5 to 10 megahertz. So what we should understand is commonly asked question. For the deep abdomen, it is less. And for superficial, it is more. Right. So ultrasound, we use the word what is called as echo. So these are mainly the intensity of the echoes, which are received back. So by the transducer. When, it doesn't receive it back, it just, that pass through. That's how you get something like, cystic. So that is what you get in hypo, transmit all the sound waves, but do not reflect any echoes. So most of the cysts, whether we get in the cystic swellings in the neck or retroperitoneal cyst, all those things are in this hypoechoic. But what happens is when the structures which reflect all the sound wave back, that you look as a very bright spots, and which has been called as hyperechoic. Classical example is bone and fat. Sometimes you have seen the reports of sonologists telling that, fat attenuation, bright fat. So all this is because of this. And pictures which reflect moderate level. So they are usually uniform grains. They are called as isoechoic. So please use the word echogenicity. So if there's a cyst, hypoechoic, but then can also be a, so there could be a hemorrhage inside. So that's how it gives. I have put this one simple, fetal ultrasound. That's how it's one of the easiest one to understand. Whenever how to read in the screen, the fluid is, always black. So you can see here, and I think you can see this is the amniotic fluid, right? Yes. Now the tissue is a gray. That is actually uterus. And the denser the tissue is the brighter. If you see the bone here, cranium. So that is looking more brighter. So I hope these very fundamentals, I hope you know now that whenever we have a case, if you see bright one, this one, bone, here is the bone, that is the cranium. And this fluid, that's amniotic fluid. And this is uteri. So that is how we proceed, right? Now these are fundamentals. So fluid is black and tissue is gray and denser is the tissue, bright. Now this is the fast. I have put one slide, important slide, because to know that focused abdominal sonography in a trauma. So this is something which everyone should know, including the postgraduates and everyone, whether it's a trauma surgeon or emergency physician or somebody there. So this is a D representing the diaphragm here. And you can see the splenic tissue. And you can see also here, it's a hyperdense here. So these are indication of a clot also, that is the splenic trauma. So there are some other things which commonly asked also, today ultrasound can be combined with the color Doppler. So obviously this is one of the greatest advantages of showing the vascularity. So color Doppler can be used. Classical ultrasound of the scrotum, testicular torsion. Of course, it is added by a Duplay there. And you can also use it for the interception, that gangrene. So this is one of the important uses of a color Doppler. Now the few things, like sometimes they will ask you, what is this enhancement, enhancement. So there could be structures that are examined looking more brighter than expected. So you call it as a, enhancement of the wall. Then there is something called as attenuation, which is the shadowing, which makes the area, whatever you are scanning, looking more darker than the expected. So these are some of the basic questions which are commonly asked. I mentioned already about the frequency, which is expressed in terms of megahertz, then echogenicity, and of course the few other advances in the Doppler. Now I just want to show you, we already mentioned stones here. So gallstones are characteristically, we call it as echogenicity. So backside you can see here, and that is what is posterior acoustic shadow. So these are very, very classical of a gallstones. And you can see inside there is a fluid there. There's a bile there. So which is the, you can see here, hypo. So this is how a gallstones are one of the easiest. So if you are asked the investigation of a choice for gallstones, it is the ultrasound actually. Is almost the highest accuracy, specificity. And so now if you look at this here, there's a patient who has come with the abdominal mass. You can see the fluid there, there's the CBD there, and this is the mass here. Of course, portal vein CBD, you can always compare. As I mentioned, fluid is darker here. And this is the showing a mass, which is hypoechoic in the body. So that is the one of the tumors of the pancreas. So it's important that ultrasound has become one of the most useful investigation today. We call it as extension of the clinical examination for a surgeon. And you can diagnose so many things. Is excellent for the solid viscous, like a liver, spleen, such a large masses. One of the problems in the abdomen is the presence of the gas. So that probably is the limitation of the ultrasound. And also we know that ultrasound is operator dependent. So these are some of the problems of using the I'm not telling it's a problem, but if you look at the uses of the ultrasound, so it has become the very, very handy now. And as I already repeat, it's an extension of the clinical examination. I'll just move on to a little bit here. If you see, there's ultrasound actually showing actual ultrasound of the breast. It's a homogeneously mild hypoechoic solid mass. They have given some dimension you can measure, a thin echogenicity and internal calcification, also or distal no calcification or no distal acoustic shadowing. It is actually a fibroadenoma of the breast. So one of the, as I mentioned to you, breast thyroids, they range from 5 to 10 megahertz here. So one of the extensively used investigation of patients who are, say, younger patients, dense breast, 20 to 40 years of age. So ultrasound is one of the important investigation of a choice where you can diagnose many conditions. This is the one example just to show you the right kidney and left kidney you can see here. So very classical fluid, right? So this is a hydronephrosis. And you can see some renal tissue also above there. There's a renal tissue. One of the extensively used investigation with which you can even diagnose is appendicitis. If you look at carefully, it's almost more than a centimeter size here. Tubular structure. There's no peristalsis. And tenderness, of course, probe tenderness. And if you see this white structure here, white structures, and that is what is the periappendicular fat stranding. So that's what I mentioned to you earlier. So if these findings are present with you can almost be sure that it is a acute appendicitis. So in other words, ultrasound is one of the important investigation of a choice in definitely an acute abdomen, may not be very specific in mesenteric ischemia and few other conditions where, of course, CT has got an upper role. But however, looking at the advantages and how quickly one can arrive at diagnosis, so ultrasound is the important test. Now, just again, a very extensively studied ultrasound of the thyroid. All of you know that thyroid's categorization is will be one of the questions which is asked to you, 1 into 5 there. Thyroid 1 to thyroid 5, 4 has got A and B. A and B is suspicious. 1 and 2 up to 3 you can call it, but as 4, 5 you can be sure. So, but important common questions which are normally asked are these, that what are the features which you can diagnose by ultrasound of the thyroid. That is the more solid component. Yes, there is a hypo or a marked hypoechogenicity, irregular microcalcification, microlobulations, taller than wide. And in addition, obviously in malignancies, that if there is a extrathyroidal extensions or even a cervical lymph nodes, obviously, more so the central and jugular chain is 2, 3, 4 levels. So you suspect that it could be a thyroid malignancy. So one of the extensively used, highly suspicious nodules, obviously ultrasound guided FNAC can be done. I just shown this. Of course, these are pictures from internet. You can see here classical how the fluid appears. You can straight away tell it is a cyst. So, and if you look at here, you can see a suspicious nodule, calcification, irregular. So all those classical of a thyroid carcinoma. So it is this is how one of the important uses of the thyroid, the ultrasound in a thyroid diseases. So one other question, probably this is to add some more, what is thyroid elastography? So whenever you have these suspicious nodules, when you clinically you may feel, but sonologically some doubts are there, you can also evaluate tissue elasticity. So this enhances the diagnostic ability. to detect the malignant thyroid diseases. They are maybe firm there or fibrosis, loss of elasticity, etc. So this is some kind of a objective evaluation of the tissue stiffness. So this is the ultrasound elastography. Right. So this much information is for the time being is enough for you postgraduates. Basic ultrasound of the breast, ultrasound of the thyroid, and of course appendix I mentioned to you. So as I mentioned, there's no end for learning. You can continue, but basic principles have to be kept in mind. I will go to some more things about now mammogram, because another commonly asked question, this mammogram from breast imaging, radiology, and data system. This is also another commonly asked question, ranges from 0 to 6. 6 is ultimately proved by pathologist, and this is how it is. One thing you should remember that compared to ultrasound, mammogram is obviously objective, but you can also add a sonomammogram whenever you have an ideal situation. There is some radiation hazard for this. Low dose, it's a very low dose radiation, but still it is there. Whenever we ask for a mammogram, it is always bilateral. Don't say that it is unilateral. Patient may come with one side lump, but we are always asking for bilateral. Also remember, if it is a unifocal, multifocal, multicentric, all this can be made out by mammogram. Ideal situation is say around between 40 and 50, but remember in India, malignancies of the breast occur a decade earlier than the Western. So it is, you can even start by 40, 45, but definitely much earlier in case of a genetic mutation, familial breast cancers, bilateral disease, and younger the age group. In all this patient with the family history, it is better that one can do very early and repeat it once in 2 years. There are common types of screening. Mammogram is the patient who come with a routine for, say, one mammogram at the age of 50. Yes, that is the screening. You may not, that's almost normal. When you have a diagnostic, means you have done a clinical examination, you have found a lump there. So then it becomes a diagnostic. That's how you categorize later. And when you have got some impalpable lesions which are picked up by whether it's a screening or some diagnosis you have done for something else, very small lump detected not by clinical examination, by mammogram, you put a wire localization there and excise the lump, and you can also take the mammogram of that. It's called a specimen mammogram. So these are some of the fundamentals of the mammogram. Now, views. Yes, procedure, of course, it's a painful procedure. So breast is compressed. So right mediolateral oblique or left mediolateral oblique and craniocaudal, two views. You can see here, that's the arm there. So there's the upper one. And these are actually vascular markings. This is only to show you the images. Superior, inferior, medial, and lateral. So this is how you diagnose. This is actually a normal. Now, if you look at the other picture here, so here you can see extensive architectural distortion. Even you can see a nipple is inverted, and there is a calcified subareolar lesion. This is in the first picture. Here in this picture, you can see here spiculated margins, calcification, branching pattern, etc. So all this will give a diagnosis, palpable lump. So this is a diagnostic mammogram, and you are pretty sure here that this is almost Bylard's category 5. So they are almost sure that these are the features of mammogram in a malignancy. Now, one of the important questions is about the calcification pattern. Just like in thyroid, we have the microcalcification, then taller than wide, and we say here also, especially the calcification pattern. Pleomorphic, the word, like we have a pleomorphic adenoma, that's a different one, but the word pleomorphic, if you look at the calcifications, some linear, some thin one, branched one, narrow, wide, so clustered. So these are all the words which are commonly grouped, as a pleomorphic, calcification. They are fine calcification. So this look will tell that this is a definitely a carcinoma of the breast. So mammogram findings can be so typical. Mammogram will definitely guide a biopsy. This is just to again shared from the internet. You can see a diffuse. This is what I mean by cluster, one cluster. And this is one segment. This is one regional. So these are some of the various forms of calcification which you get in mammogram. So these are some of the favorite questions: microcalcification, diffuse, branching, linear, thin, fine, clustered, segmental. So speculated margin, they are reflect the architectural distortion. So these are findings in a mammogram. I mentioned to you, one is a diagnostic first is the screening. Second one is a diagnostic. Now, if you look at this is a specimen mammogram. As I mentioned, impalpable, lumps, impalpable lumps. You have done a wire localization here. You can see the wire there. See there. So, and you can see the specimen there excised. And you have done the specimen mammogram. Just show you whether I can show that. Yeah, this is the one. You can see the wire there, correct? So that's how it is. So this is the classical specimen mammogram. So these are the three types. The idea is to know that you have done a wire localization for an impalpable lump, and you have taken the patient to the operation theater, and you excise the lump, and obviously this is the specimen which you are going to take a specimen mammogram to get an idea that whatever you have removed is there with that needle or with the wire. And this, of course, will be sent to the pathology. So these are the important types of the mammogram. Now, this is, of course, obviously a advanced lesion. You can see here axillary nodes above. So obviously, can you see here? Yes. So just want to show you that enlarged view once. Yes. So see here, you can see the axillary nodes, and you can also see the calcification, so branching pattern, etc. So this is obviously a carcinoma of the breast. Now, this is not related to the breast calcification, but examiners, as I mentioned to you, they tend to deviate and try to check your knowledge sometimes. What are the different types of calcification? So as you know that classical thyroid nodule, you get, there could be a hemorrhage, or there could be a long-standing, you call it as a dystrophic calcification. Hyperparathyroidism is the one disease where, there is a hypercalcemia, you get a metastatic. Metastatic does not mean that metastasis. It is the metastatic calcification everywhere. There are a lot of findings are there. I think you can read about that. Disease of the bone, stones, etc. Now, idiopathic, of course, is the familial. Iatrogenic is extravasation. When you index some dyes, severe extravasation would happen, calcium-based dyes. And last one is a calciphylaxis, is nothing but chronic renal failure and dialysis. You do get this. So these first two are the commonly asked questions. So we have done with the basic ultrasound and mammogram. As I mentioned to you, more the films you see, more will be the idea you will get, and you'll be able to read. Now we'll go to some basic CT scan. You should know that Hounsfield is the person. British actually is British, electrical engineer, who is the one who shared the Nobel Prize. Forgot to tell who is the other person along with him. Way back in, I think, 1979. And he got the Nobel Prize for this invention of the CT scan. That's why it still goes in the name of Hounsfield units. I hope you know. Whenever we talk about the CT scan, we talk in terms of Hounsfield units. We'll tell about that, also called as numbers. So there are few basic things, just like the ultrasound we mentioned, how the fluid looks dark there in ultrasound, right? Gray means solid tissue. Similarly, I mentioned in the bone, in the ultrasound, bone is white. There we use the word echo, whereas in CT scan, we use the word density. Now, structures which appear densely white here, too densely black, all depends upon how much they absorb the X-ray. So, emerging resulted X-ray are the one which are detected here. The composite picture, what has been called as Hounsfield numbers, they are based on Hounsfield units, right? So there is something called as various shades are there, out of which the gray depends upon which we'll use the Hounsfield units. Now I will give this. This is the one slide which you should know, because whenever you watch a CT scan, you are going to see what is this black thing looking. So that is the air. Air has got the highest, minus 1000 Hounsfield units. So then fat. So always when you are given a picture, subcutaneous is always, there is a fat there, subcutaneous fat. So you can compare how much is the bright fat is this, how much is the air, minus. See, this minus is air and the fat. Rest, you can see the range starting from the water. So 0 to up to calcification of bone, which is 1000 Hounsfield units. So in other words, a gray matter of the brain, clotted blood. So one of the greatest advantage, as mentioned for the CT scan, is it is objective, unlike the ultrasound, which is subjective. Ultrasound has got definite advantage, as I mentioned, that it is very, very handy and no radiation hazard. But remember, CT scan has got a radiation hazard. And more so when you are using especially contrast. When you are using a contrast, one should be careful to look after the dehydration part of the patient. And you should also see creatinine values. I think that's a bare minimum thing which postgraduate should know, that whenever you ask the contrast is given, contrast-induced nephropathy is one of the dangerous problems. So hydration and creatinine. And remember that when you are asked, especially diabetic patients, obstructive jaundice patients, there are various combinations here. They may be already on gram-negative drugs, gram-negative, antibiotics. For example, amikacin or gentamicin. Their creatinine levels may be high. At the same time, they also may be dehydrated, waiting for the adding on everything. It will give rise to contrast-induced nephropathy. So keep it in mind, creatinine to be done. Some of the types which include here is the first one is the plain. Normally, most of the abdomen, we always ask for the contrast CT. Because when you give a contrast, it gives a very good idea what are the contrast agents which are used. So just to quickly to tell, mannitol, water, thin barium, gastrografin, that's a diazote meglumine and diazote sodium, iodinated contrast. These are the various contrast agents which are used whenever we do a CECT. There are sections like coronal, axial, and sagittal sections. There are important phases like arterial and venous. And whenever we have a pancreas, we also take a parenchymal phase. Sometimes you also, is classically to diagnose a liver cell tumors, you also take a portovenous phase. So there are so many advances which have taken place in the CECT scan, but I just given you some principles. It is for you to read. Now I will show you this picture. One picture has got some important information here. I just enlarge and show you. Yes. Where is it? Yes. Okay. Now, if you see the first picture, there's an axial section. There is a plane. You can see there is a mass lesion. But if you see in the second picture, if you see the second picture, which I have enlarged now, sorry, here, right? You can see very nicely, there is an aorta there. So obviously, you can see it's brightly enhancing. This is the aorta. Now, if you see the first picture I mentioned to you, no, this is the mass. But if you see the second picture, arterial phase, you can see extensively the lesion. Now, if you see the portovenous phase, last phase, here it is not enhanced like this here, bright spot. This is a, here you can see this is the washout phase, also called as portovenous phase. So this is a very, very classical hepatocellular carcinoma. So the imaging is so good that one should be able to diagnose. So especially in the liver, we talk about this three phases: arterial, the plain, arterial, and venous, and of course the portovenous phase I mentioned. There are few examples we will see now. If you look at this scan here, again, you have to look back and see. I already mentioned to you how much is the Hounsfield units. You can measure and see also here a multiseptate, right? You can see hypodense lesion. We use the word density here, and you can see the septate there. So very, very classical appearance of a cartwheel lesion. This is actually cartwheel appearance, and very classical of hydatid cyst. And once hydatid cyst is given to you, obviously the other questions they will ask you is, this is a space occupying lesion. So what are the other lesions? You just saw earlier how the important lesion in the hepatocellular carcinoma appears in the liver, very irregular lesion. On the other hand, how the fluid appears here and how the septae appear here. So you can see also about part of the lung shadow there, black, you can see here. So it's probably the fifth space above. So bare area of the liver, one of the common sites where you get this hydatid cyst. And yes, the usual treatment of mebendazole treatment, and then such a multiple cysts may not be ideal for a para treatment. You have to give a longer course of the treatment here, and the para is of course aspiration, injection, and ultimately repeat one. So now here it is important to differentiate this. Yeah, another picture of same thing. Here septae are seen, but here it is not seen. Whatever you are seeing is one of the important images here to know that this is the liver. And remember, this is a contrast given here. Is a oral contrast here. So that is how you make a diagnosis of a hydatid cyst. Now, if you look at this lesion, as I mentioned to you, air. See here, you can see here dark complete. There's a lung here. You can see the liver, bright spot arterial, and look at the wall here. Is also enhancement is there. You can see it very nicely. This is what's called a double target sign, abscess. So double target sign, you can see here very nicely visible. So you can see the bones also here, how white they are, and this is the air. So this is how you make a diagnosis. Now, this is another imaging CECT showing that, of course, obviously kidney. You can see this is the normal kidney on the right side, and this is a left, very, very large mass occupying the upper pole. Parenchyma is compressed here. You can see the posterior muscles, and also having one more hypodense lesion. It is present in the liver. So this is a renal cell carcinoma with a metastasis in the liver. Now look at this another picture. Yes, this is to show you only the distended gallbladder, very classical. And you can see here very, very large, again, common bile duct, which is dilated here. So again, a contrast CT scan. So arterial phase, you can see a bright artery there. So we can't really diagnose by looking at the one picture. CT scan is a series of pictures. But whatever the important findings I am showing you here, to know that there's some intrahepatic radical dilatation you can see here. So this is obstructive jaundice. We'll always correlate and will cause the growth in the periampullary region. So this is how you make a diagnosis in the CT scan. So in acute pancreatitis, one of the questions probably they may ask you that when do you do the CT scan? Normally, in the early part, it is not done. It is usually done after 7 to 2 hours. Obviously, if the patient is not improving, one of the important reason is to look in the early part, 3 to 4 days of time, is the arterial phase, especially for the pseudoaneurysm formation. Necrosis, if you want to see, it's called a parenchymal phase. It is done usually later, after 1 week, 2nd week, etc., where you find a necrotic. And of course, we also do the portovenous phase. Contrast, as I mentioned to you, simple water can be given. Normally, you keep the patient for 3 to 4 hours. Usually, these patients are on empty stomach for different reasons. So, give some first, initially some 250 ml you give, and after that you can do a scan. Then, of course, 500 ml is given over a period of 20 minutes. So, yes. Similarly, in the pancreatic tumor also, we can do a triple phase, again, which includes arterial. Initial part is to know the vascularity, vascularity of the tumor, including a neuroendocrine tumor. Pancreatic phase is, you can also hyperhidrotic tumors such as pancreatic ductal adenocarcinomas. And of course, portal venous phase, as I mentioned to you, for hepatic metastasis, venous thrombosis, etc. Excuse me. Yes. Now, if you see carefully here, there is a pancreatitis, extensive pancreatic necrosis. You can see here and there necrosis also, and there's a pancreatic tissue. So it's a pancreatic parenchymal phase. As you can see, a lot of fluid also around here, everywhere. So a classical of a pancreatic necrosis. Again, you can see here, oral contrast has been given, and a nice cyst, hypodense. Remember, there is no wall enhancement here. Typical situation behind the stomach here, and there's a classical lesser sac position, and this is a pancreatic pseudocyst. So as the name itself says, there is no epithelial lining, there's no wall enhancement here. So if there's a wall enhancement, it goes for other tumors. This is just to compare the the clinical picture of a large pseudocyst and versus, of course, this is a long back taken. Picture is shown for those sometimes the quiz winners. You may be asked the classical color of the pancreatic fluid, and that is appearance of a car engine oil appearance. Yes, this is that large swelling, common epigastric mass, very common, rather common long case, large epigastric mass there. A alcohol patient coming with after 6 to 8 weeks later with a large epigastric mass, and you have done a classical CCT here showing a hypodense mass, and this is the pseudocyst, and of course cystogastrostomy with the laparoscope. Of course, I am not going to the details here, but remember, symptomatic cysts have to be treated. Now, same picture, you again compare here. White I mentioned to you, ribs, these are the bones, right? Now, and this black thing all surrounding, you can see the fluid. And here you see again air in the center. So this is a very classical of a necrosis. One of the important urgent indication of a extensive pancreatic infected necrosis. So Atlanta classification is modified, is the commonly asked question. And such patients, of course, require immediate treatment and classical, whatever the approach, step-up approach or whatever it is. Yes. So this is the infected pseudocyst. Now, if you see this scan here, so right iliac fossa, these are the iliopsoas muscle. You can see the muscle there again, bone looks white here, and there is a mass, hypo as well as hyper here, and it is just showing if you see carefully there, with air pocket inside, and that is the distended cecum. This is an appendicular mass. So patient who had appendicitis with, of course, perforation difficult to make out here, but a large appendicular mass. That's how you make a diagnosis of a in the CECT scan. Show you some picture of a subphrenic collection. Again, see here. I hope you can see your coronal section there. And there's a drainage tube kept in this. So air pockets are also inside. A classical subphrenic collection. You can see the lung parenchyma here. Yes, CT of the neck. If you see here, of course, lung shadow is very clear. And diagnosis, you can make out one of the important cases for you. That is the retrosternal goiter. You see this? The second picture, probably it will be more clear. How you can see the vertebral arteries, how it has been pushed here like this. So this is a large papillary carcinoma of the thyroid with the retrosternal extension with the mediastinal nodes. So normally it is the single phase which is taken, and this is the classical retrosternal goiter. One of the quiz questions here, you can see, yes, you can see an abdomen is distended, but not much of fluid there. It's obesity there. Carefully, if you see, this is the scrotum and collection of the fluid there. Yes, you can hydrocele. Look at the cocooning effect of the small bowel there, a lot of reaction. And if you see this structure, I want to show you this structure. Yes, you can see the enhancement also here, plus fluid there. And look at the difference here and here. So this is actually a distant, sorry, not distant, it's a urinary bladder. And this is a large giant hernia. This is the large hernia. Bowel is all, you can see here how cocoon like, with lot of fluid there and with bladder. This is, of course, is the classical sliding hernia. Another scan, you can see testicular tumor, large parietic nodes, and of course the liver secondary. So in other words, the extensively CT scan is being used now, and to that extent that straight away one asks for a CT scan, thinking that you can get a diagnosis, provided there is no contraindication. One can be very, very, very objectively, you can get so much information on the CT scan. Another interesting case, there's a contrast given. There's the stomach. You can see here a large tumor. You can see here, and inside there's a air there. And this is the same specimen which we removed. You can see the specimen, actually wedge excision. This is an open specimen of the stomach. You can see the rugae there, and you can see some kind of a crater. This, if you were to do we have done endoscopy actually. I don't have that image. It shows, it's called as a cervix appearance. In such cases, biopsy on a biopsy or taken, because most of them are submucosal. But in this case, it was ulcerated. This is, of course, a gastrointestinal stomal tumor. So last part of the CT scan here is to show you an extradural hematoma there. If you see the lens-like, lens. So it's called a lenticular pattern. So that is the classical, gray matter is shown here. There's the skull white. So typical extradural hematoma. So these are few of the CT, abdomen, and neck also I have shown you. But basic principles have to be kept in mind here about the density and Hounsfield units. Commonly, since it is the commonly asked question, I have included CT angiogram now, because peripheral vascular disease or arterial occlusive disease is another common problem. So today, the Seldinger's method of retrograde is not done, but I'll show you one picture so that you know that to answer that. These are the iodine-based contrast is given through intravenous route. So what's the big advantage now? You can avoid an arterial puncture. So whenever you have an artery is punctured, there's a chance that pseudoaneurysm formation, thrombosis, several other complications can happen, bleeding. So you are giving intravenous so that you get the entire picture. So you don't have to puncture the artery at all. So this is how you diagnose various image of the blood vessels and which are well perfused. Whenever we do angiogram, few things to be remembered. Always, iodine allergy, thrombosis, vagal inhibition, damage to the nerves, even the artery can undergo spasm. So these are some of the important complications of the angiogram to be remembered. So if you see this picture, here I think I will enlarge and show you. Yes. See that? This is the superficial femoral artery. So typical place of when it passes through the adductor canal, you can see the narrowing there. And look at the stent which is in place here. So normally, so once the angiogram is done, the catheter is advanced and through which a balloon dilatation of the segment can be done, followed by a stent which has been kept here. The stents there are various types are there, including nitinol stent, which is one of the things which is shown here. So the post-angioplasty picture is showing a well vascularized. So today, the peripheral angiograms and angioplasties, balloon dilatation has become the standard, gold standard treatment. Unlike earlier, the question which was asked was that when do you do angiogram? Only if you do revascularization. That is not the answer today. Every case of the peripheral artery occlusive disease, the angiogram is done. Whether you will do a surgical bypass or even today infrainguinal bypass, even infrapopliteal revascularization to extent of 2 to 3 millimeter PD's arteries also. So balloon angioplasties are done. So peripheral angiogram, one should know detail in at a postgraduate level. Again, show you a picture. There's a common iliac artery having two branches here. And you see here, I have just encircled. See that narrowing there? So just show you again. So yes, see here. And look at this picture, how nicely the artery has responded. So this is a very important part of the treatment of peripheral arterial occlusive disease. Once the diagnosis is done, irrespective of the level of the arterial occlusion, there may not be an excellent result for a small vessel disease, especially in a diabetic. But remember, the ulcer may heal better. So the reason why even a 3 millimeter, 4 millimeter arteries also can be dilated. So angiogram is a must. To know also distal flow, collaterals, it will give an excellent picture overall, distal runoff. So this is the peripheral angiogram. Again, superficial femoral artery occlusion. So I mentioned about Seldinger's. So in other words, you look at the difference. This is not a CT, obviously. This is the peripheral arterial angiogram, where we used to put a catheter from a direct puncture and advance the catheter. That's called a Seldinger's method. It's a retrograde. So from the femoral artery, feel for the femoral artery pulsation local and put a catheter up to the aorta and inject the dye. So obviously, it will fill up both aortas. And you can see here, this is okay. Now here, occlusion is at the superficial femoral artery. So retrograde angiography is now rarely done. So rather we should not do, where there's a CT angiogram is available everywhere. So that is the gold standard. Yes, just to show you one image here. Look at here carefully. This is a common carotid artery. You can see the classical splaying of the artery. This has been called as a lyre sign. It's a musical instrument. And this is a carotid body tumor. So carotid body tumor, the classically bifurcation, chemodectomas. So that's a lyre sign. So these are few important parts of the Yes, this is a gastroduodenal aneurysm, and just to show you one picture, and it's a complication of acute pancreatitis, and which is of course later embolized. Um, I have some more minutes, so I just show you the ERCP. Now, if you endoscopic, you can see the scope first whenever you identify an X-ray. Retrograde cholangiopancreatography. Here, of course, pancreas is not visualized properly, but you can see a cystic duct here, and you can see the gallbladder. You can see left hepatic and right hepatic duct. Now, what does this picture show? So, whenever you are asked, you are going to tell that's an ERCP, and you can see gross dilatation of the common bile duct looks like more than 1.2 to 1.5 centimeter dilatation. Intrahepatic dilatation, you can see biliary radicals, and you can see multiple filling defects. So these multiple filling defects are suggestive of stones. You can see they are very regular. They are looking like the faceted stones. Please remember, ERCP is an endoscopic retrograde. You're going to pass through the ampulla of a Vater, through the sphincter. So it's an invasive procedure. Please remember, it can introduce infection inside. This is an obstructed system. Already patient has got indication for ERCP. The stones are there in the common bile duct obstructive jaundice case. So with antibiotic cover, you can extract all these stones and put a stent later, of course, followed by cholecystectomy. Another question which is commonly asked is, especially periampullary carcinoma, if you want to diagnose, don't say ERCP. You just have to visualize the ampullary region or periampullary and take a biopsy. So it's a side waving scope. If there is only a lesion at the terminal, ampulla of Vater, there's no point in introducing the infection inside by doing ERCP. Just that you want to do a biopsy. That's all. So otherwise, if it's an inoperable case, to put a stent, yes. Or patient has got cholangitis, or you are to buy some time to do the case. Patient has got intractable itching, very intractable itching. There could be some delay in surgery. Yes, you can do, but otherwise, ERCP is not the answer. This is one of the common mistakes done. So it's only for a diagnostic there to biopsy. This is, of course, choledocholithiasis. And just to show you that ERCP showing lower CBD is seen here, but you can see upper one, intrahepatic very thin one, and you can see the clips. This was a partial clipping of the common, this, sorry, just show you once. Yes, look at that. So you can see the clips on the common hepatic duct actually, post cholecystectomy, but not transection. Bile is the still you can see the dye gone up. So that is the partial clipping, and this is you can see a complete transection of the common bile duct. Suddenly, when you are put this picture, one of the common mistake done is this also you will tell ERCP. Look carefully, this has been already shown to you, but now look this picture. So this is, you can see a tube there coming out. This is a T tube. There's no gallbladder, a little bit bile leak may be there. So this is the common bile duct, looks dilated. This is a T tube cholangiogram. It's some of the questions which are commonly asked. Please read about it. What is on-table cholangiogram? Yes, OTC. If you are not sure about the anatomy of the cystic duct, common bile duct in the open method or on-table, but generally even in the laparoscopic method, there's a tendency not to do on-table cholangiogram now. Okay. Then you have to explore the common bile duct for the stones. After that, this is what used to be done. We put a T tube there, and 8 to 10 days later, we do a T tube cholangiogram to know any retained stone. So that's how it is. And if you see this picture here, that's the T tube cholangiogram, and lower down there is a retained stone there. I hope you can see there. So that's how it is. So it's a real postgraduate question. You can see here. When do you do the T tube cholangiogram? What are the types of cholangiogram? I mentioned to you on table, post-exploratory, post-operative, this is the 8th or 10th day. What precautions you take? We should not inject the air bubble inside when you are. What is the T-tube made up of? Latex. When do you do it? When do you remove the T-tube? Yes, provided dye should go freely into the duodenum. Patient should not have pain while injecting, or patient should not have jaundice. So there are some criteria where you remove. And if there's a retained stone, of course, you can still try an endoscope and remove it. And if there's a recurrent disease, CBD, recurring stones, what other alternatives? Just want all of you to read something more details about the role of a choledochoduodenoscopy. Choledochoduodenoscopy. So these are some of the important information which you need to know, right? So that's about the T-tube. So I think, sir, I will stop now. That's
yes, sir.
I will stop now. And
Yes, sir. I think we have Professor Abhay Dalvi, Rajesh sir, Hitesh sir. Sir, would you like to add any points or give your comments, sir? Dr. Abhay Dalvi, sir.
Everyone is welcome because this is a little longer session, and everyone has got rich experience in the imaging. So whatever possible I have done. Thank you.
Professor Hitesh sir, your comments, sir. Rajesh sir, hi, sir. Hitesh sir, you are in mute mode, sir. Rajesh sir, please unmute yourself. Not able to mute, sir? Try now, sir.
Okay, yes. Right, good evening, sir. Sir, as usual, excellent talk, very comprehensive. The densities about in CT scan and how to read them is very important, because that's how we know whether a thing is solid or liquid or fat or air. And very nice. I think you should give us a bit more on CT and MRI. I'm looking forward to it.
Yes, sir. Excellent discussion and very basic information, which probably the clinicians and the students of surgery department are lacking. Units, what is hypoechoic, what is hyperechoic, what is anechoic. Few more things, as Sahai sir has told, can be discussed, but I think we have a time constraint. Just the individual case, like if it is a periampullary carcinoma, what are the things to be seen? If everything is normal, curable, angiograms to be seen to know for abnormal vessel. But I think that it is beyond the capacity of 1 hour. Students can learn that, but whatever sir has said is basic information. Probably everyone can go through this repeatedly and remember. And if they can answer these basic questions, probably they will get more than average marks. Excellent presentation, sir.
Thank you. They have to obviously see the more imaging, and because
Yes,
clinical examination today does not stop only at the clinics. It will continue with this.
And even all images and individual cases are endless, even on imaging topic.
Professor Vijay Kamath, sir. Sir is not there. But anyway, sir, I'm very happy.
Hello, sir. Hello, sir.
Sir, we'd like to hear your comments as well. You've been...
I just joined late, and Rajgopal Chennai, sir, is an excellent teacher. Very known to me. We were examiners together, very known to me. He's an excellent teacher. Whatever he teaches, he conveys the message.
Agreed, sir. Agreed.
I could have spent some time in KMC Manipal. The amount of material sir has collected over so many years is an evidence for the amount of clinical work that is happening, sir. Very much impressed, and almost all the pictures are from his own collection. So thank you very much, sir. It should have been collected over years now. and everything was very lucid and with absolute clarity. I could see Professor Abhay Dalvi sir's hand up, sir.
Dalvi sir wants to tell
Yeah,
something.
good evening.
Sir.
I only want to say excellent presentation. The thing is, our students have to know clinical radiological correlation.
Yes.
There are CT scans which will show you perforated appendix. Patient is absolutely normal. I am right now treating one of them.
Yes.
So all these things have to be brought into picture, and then the patient will be safe and active. Thank you so much, sir.
Thank you, sir.
Any comments from the other senior faculty here? Thank you very much, Rajgopal sir. Now, with your permission, we call the first half of the session close, and then we now move on to the next session. All of us, please bear with us for